Bismillah ar-Rahman ar-Rahim. The topic of our lecture today is about errors of refraction. In the last lecture, we spoke about myopia, presbyopia, and astigmatism. And now we are going to speak about another two topics, which are presbyopia and anisometropia. Presbyopia means physiological recession of the near point of distinct vision beyond the normal reading or working distance with accommodation fully relaxed. If you look at your parents or your grandparents, if you give them something to see, they put it away from their eyes. That's because they have actually a kind of farsightedness that is related to the age, and it's not actually farsightedness, but they cannot see near objects and they have to put it away from their eyes in order to be able to see it. Two important factors or points in this definition. It's physiological. This means that it's not a disease. If we speak about diabetes, about hypertension, or anything else, it is a disease. So it occurs to some people only. But the word physiological means it's not a disease. It's something that happens to all the population. And the other word is that accommodation fully relaxed, because if you use your accommodation, you're going to counteract presbyopia. That's why it's very important for the definition to insist on this. It's a physiological recession, so it happens to almost everyone, and with accommodation fully relaxed. Let's look at this slide on the mechanism of accommodation. We all know that the refractive media of the eye is composed of the cornea, which has a refractive power of about 4 plus 42 diopters, and the crystalline lens, which has a refractive power of about plus 18 diopters inside the eye. The lens is held in its place by the zonule, which is attached. The zonule is attached to the zonule or the suspensory ligament, which is attached to the ciliary muscle. So how we see near objects and far objects? To look at infinity, we don't need to use our accommodations. But if we want to look at a near object, the ciliary muscle contracts, so the zonule relax, and the lens becomes more convex. This means that the convexity of the lens increased and the diopteric power of the lens increased. So the eye becomes more myope. This means that the eye is able to see near objects because it becomes more myope than it used to be. So this is the mechanism of accommodation: contraction of the ciliary muscle, relaxation of the zonule, and increase in the lens curvature to increase the diopteric power of the lens and see near objects clearly. So in this we can see that the eye acts like a camera, with the crystalline lens is the lens itself, and the retina is the film of the camera that the crystalline lens focus the image on the retina. And in order to see near objects, the crystalline lens increases its power to focus the image on the retina. So the etiology of presbyopia. If we look at the factors affecting the onset of presbyopia, the first factor is the age. Presbyopia started to appear around the age of 40 or 45 in an emmetropic eye. The emmetropic eye is the eye which is not myope or hypermetrope. So if you have a normal vision, you will start to suffer difficulty with near vision around the age of 40, 45. It depends on how are your visual needs for the near vision. Refractive error. Presbyopia occurs earlier in the hypermetropes because the hypermetropes uses part of their accommodation in order to see far objects. So they consume part of their accommodations and the remaining part for near objects is small. So it's expected that hypermetropes suffer presbyopia earlier than myopes. On the other hand, myopes never use their accommodation because the accommodation makes the eye more myopic, so they don't use their accommodation, and that's why they are able to see near objects. If you have a myope of -1 or -2, he will be able to see near objects clearly, although he is not able to see far objects. So the second factor in affecting the onset of presbyopia is the refractive error. The third factor is the preferred working distance. This means that how much do you need your near vision? So people doing near work experience presbyopia earlier than those doing intermediate or distant work. If we look at different occupations, if you are a tailor, as you need to work with a needle on a 10 to 15 centimeters, of course you will suffer presbyopia earlier than a banker who looks at his computer screen at 60 centimeters, and he will suffer presbyopia earlier than a driver that doesn't use his near vision and he is not aware of his presbyopia or his problem. So the factors affecting the onset of presbyopia include age, refractive error, and the preferred working distance. And currently people become more and more aware of their presbyopia. And why? It's because of the mobile and cellular phones. Everyone is looking at his mobile or cellular phone, and after the age of 40 or 45, recognize that he cannot read his mobile or text very well, and that's why they seek treatment and they go to the doctors complaining from near vision defect. What are the symptoms of presbyopia? The symptoms of presbyopia include eye strain, headache, and indistinct small blinks on reading at night, indistinct reading or not able to work at daylight also, then failure of all near work. It's very simple that presbyopia, the symptoms of presbyopia, failure of near work. The patient cannot see near objects clearly. The patients cannot see near objects clearly, and that's why they suffer from this presbyopia. How to correct presbyopia? It is basically the same but the main correction of presbyopia is with glasses, contact lenses, and refractive surgery. But the main correction of presbyopia is actually with glasses. We use glasses to correct the presbyopia, and we either have separate glasses, one for distance and one for near, or we have bifocal glasses that use half the glass for distance and near, and the same glass for distance and near. It has two points, one for distance and the other one for near, or multifocal glasses that have different focus of the same lens and the patient uses for distance and for near. Contact lens, we also have multifocal contact lenses that can fashioned to be used for distance and for near, and refractive surgery for presbyopia by different means, but actually the most convenient way to correct presbyopia is with glasses and not contact lenses or refractive surgery. So this is the first topic of our lecture today, speaking about presbyopia, which is physiological recession of the near point of distinct vision beyond the normal working or distance for near, and with accommodation fully relaxed. Now we are moving to the second half of our lecture, which is anisometropia. Anisometropia is difference in the refraction between both eyes. So this means marked inequality in the refraction of the two eyes, with a difference of more than 2 to 4 diopters between the two eyes. So if you have a difference between both eyes, this is called anisometropia. Anisometropia is very critical, and it has many challenges. The first challenge of anisometropia is that it cannot be diagnosed because the patient usually have a sound eye or an eye that can see very well. So he doesn't recognize that the other eye is weak unless he closes the sound eye. And so in children, it could not be, it's not easy to diagnose anisometropia until the parents seek consultation by the doctors. What is the etiology of anisometropia? Anisometropia might be congenital, and this is the most common. We all know that when we are born, the eye is small and we mostly hypermetrope, and then we come to emetropia, and then if you progress to myopia after that. So the first cause is congenital, most common, one eye is larger than the other eye, progress of myopia in one eye, or recession of hypermetropia in one eye, so one eye becomes hypermetrope and the other eye becomes more hypermetrope. Operative trauma, ocular disease, unilateral aphakia. For example, you can have a patient who is myope -1 in one eye and -9 in the other eye. This is called anisometropia. Or a patient who is hypermetrope +1 in one eye and +6 in the other eye, and this is also called anisometropia. How is the refraction in anisometropia? In anisometropia, we have one eye is emetropic and the other eye is ametropic, whether it is myope or hypermetrope. So, like I said, one eye is normal, 0 refraction, and the other eye is -4. This is called anisometropia, myopic anisometropia. Or one eye is plano or 0, and the other eye is +4. This is called the hyperopic anisometropia. This is the first type of refraction in anisometropia. But if we look at the second type, both eyes are ametropic, whether both are myopes or both hypermetropes, or one myope and one hypermetrope. Both eyes are ametropic, both are myopes, means one eye is myope -2 and the other eye is -8. Both are hypermetropes, one eye is +2 and the other eye is +6. So this means that this is hypermetropia, but anisometropia at the same time. Or one eye myope and the other eye is hypermetrope. So if you have one eye -2 and the other eye is +2, this means that the difference between the two eyes is 4 diopters, and this patient will suffer also from anisometropia. Clinical picture of anisometropia is actually the patient, usually there is this is the second challenge of anisometropia. Difficult to diagnose, and it has consequences. It has problems if you don't diagnose anisometropia, that especially because it occurs in children, it has very bad consequences on the vision development in children. First, the patient suffers from eye strain. Actually, most of the children did not complain. So if the parents did not take the child to the doctor to examine him or her, the anisometropia will never be detected. So first, eye strain. Diplopia in some cases, if the patient has one eye normal and the other eye is -10, the size of the image on the retina is not the same. And in order to see one image, it has to fall on corresponding point of the retina, and it has to be of the same size. So if the image is not of the same size, the brain will start to suffer, the child will start to suffer from diplopia. But at this stage also the child cannot complain. So the brain will start to find a solution for this diplopia by suppression of the bad image, then neglection of the bad image. And suppression means the patient prefers to use the good eye and neglect the bad image from the other eye to make the diplopia disappear. But prolonged suppression and the neglection will result in amblyopia. Amblyopia means the eye is no longer seeing, partial or complete amblyopia. So this means that if the patient continue to use one eye during the development of vision, the other eye will suffer from suppression, neglection, and amblyopia. Amblyopia means irreversible suppression. And when the eye is not used, it's going to take the resting position. So in neglected cases, the child might have squint. And actually what we see in the adults like 18 or 19, 20 years old, one eye is squinting. And when you examine this eye, you find it myope -10. The patient is not using it. He's fixing with the sound eye, and he is not using the bad eye, or as we say, it's a lazy eye. It's a lazy, what we call lazy eye. So this is the second challenge of anisometropia, is that it has, the first challenge is that it is difficult to diagnose, and the second challenge is that it has a bad consequences if not detected and treated promptly in children. The child develops amblyopia and squint, and amblyopia means is irreversible in most of the cases, and if reversible, it is not totally or completely reversible. Types of vision in anisometropia. How a child with anisometropia sees? We all see binocular vision. We see with both eyes. So if we have a difference of 2.5 diopters or less, this is the limit tolerated for good binocular vision. As I told you, in order to see binocular with both eyes, the image should fall on corresponding point on the retina, and the image should be of the same size in both eyes. So any difference in the magnification due to anisometropia or difference in the position of the image due to squint will result in diplopia or double vision, and the brain will start to solve the diplopia by suppression, neglection, and amblyopia, and binocular vision is lost in a way or another. But 99% of us has binocular vision. Alternating vision is one eye is myopic, used for the near, and the other eye is hypermetropic, used for far. So this means, or the strong eye for the far distance and the weak eye for the near. This is actually what we have. If one eye is myope at short sight, the patient uses for near, and the other eye is normal, the patient uses it for far vision. And actually, all of us have a dominant eye that's used mainly for distance vision, and a non-dominant eye that's used mainly for near vision, but we have binocular vision. But alternating vision happens only when the patient has anisometropia, and we have a mix of binocular and alternating vision. Uniocular vision, when one eye is deeply amblyopic. One eye is very weak, suppressed, neglected, and then becomes irreversibly neglected. That's amblyopic, so the patient starts to see uniocular. And this is the second challenge, as I explained to you, is the very, very bad consequences of anisometropia if not detected and treated promptly during childhood. What is the correction of anisometropia? We used to say in errors of refraction that the correction is with glasses, contact lens, and refractive surgery. But in anisometropia, we need two criteria for the correction of anisometropia. We need a permanent and full correction. We need a permanent and full correction to avoid the development of amblyopia, and to avoid the bad consequences of anisometropia. So if the patient uses glasses, this is not a good solution for anisometropia, because the glasses will result in difference in magnification of the image, and also the child will suffer from the diplopia and amblyopia. Contact lens, it's not practical in children to let them wear contact lens. Also, contact lens is a good solution because you put it directly on the cornea, so the magnification or mimification of the image is nil. So it helps the patient to develop good binocular vision, but it's not a permanent solution because the child will wear it sometime and take it on and off, and this is also will result in the development of amblyopia. Refractive surgery is a good option for the correction of anisometropia in children, and the aim here is not to get rid of glasses, but to help the patient to wear glasses that is consistent between the two eyes and to help the development of vision during the critical period of vision development of the brain and avoid the occurrence of amblyopia. So this is, though it is not the ideal age for refractive surgery to be done before 18 years old, but in anisometropia, we might do refractive surgery to help the patient wear glasses and to help the development of vision. And the aim of refractive surgery here is not to get rid of glasses, but to prevent the bad consequences of anisometropia, including amblyopia and squint. And the treatment doesn't end by this way for anisometropia, but after correction of the error, we have to work on this eye by occlusion therapy, close the sound eye, and allow the patient to see with the other eye, whether with glasses, contact lens, or after surgery, to train the eye and orthoptic treatment for the development of good binocular vision. So as we see, anisometropia in the children is very critical. It has many challenges. It has difficult diagnosis, bad consequences, and the confusing management. So if you are a pediatrician, if you are a gynecologist, if you are an ophthalmologist, if you are a general practitioner, you should be aware of what are the consequences of anisometropia, and you should advise the children and the parents to seek examination or consultation by an ophthalmologist to detect anisometropia and to avoid the bad consequences of anisometropia. Our last topic today actually is not present anymore, which is the aphakia. Its absence or removal of the crystalline lens from the eye, and it could be congenital, that's very rare, or acquired following surgery or trauma. The signs of aphakia include limbal or corneal scar after cataract surgery, deep anterior chamber because the lens is no longer there, so the anterior chamber is deep. Tremulous iris, iris is not supported, so it moves with the movement of the eye. Peripheral iridectomy, and we usually do it with cataract surgery. Jet black pupil, the color of the pupil is jet black, and presence of only two Purkinje image due to disappearance of the Purkinje lens. The optical problems of aphakia. Of course, if you remove the lens, the patient will have hypermetropia against the rule astigmatism due to the incision of the cataract. Loss of accommodation because the lens function is accommodation. Accommodation is a function of the crystalline lens. If you remove the crystalline lens, the child or the person will lose his accommodation, and he has to wear accommodation, result in early presbyopia, and he has to wear glasses for distance and glasses for near. Anisometropia in unilateral cases, and anisoconia in unilateral cases, different in the size of the image in unilateral. Correction of aphakia include the best is the intraocular lens implantation. If you have a good posterior capsule, you can implant in the posterior chamber, which is ideal, in the anterior chamber, or a posterior chamber iris or scleral fixated in the posterior chamber, or you can implant in the anterior chamber with a phakic IOL or kind of the phakic IOLs or the iris supported IOLs. Refractive surgery to correct the error resulting from presbyopia, contact lenses, and lastly glasses, which is actually also is not a good correction, especially in unilateral, especially in cases of unilateral aphakia. And thank you very much for your attention, and hope to see you in person very soon, inshallah.